One. Please start, ma'am.
Good evening, everyone. It's a great pleasure and welcome you all for today's webinar, Oncology Cancer Treatment Updates 2023. It's a great pleasure to welcome you all and Dr. Manish Sharma sir, Medical Oncology, Unit Head, Action Cancer Hospital, Delhi, for giving the welcome note. Please start, sir.
Good evening. Thank you all for joining this Oncology Cancer Treatment Update 2023 at this evening. And this cancer update is basically on the topic of lung cancer. And lung cancer, as we know, is the most common cancer in the world. And I think the most important changes which have been made there in lung cancer, and no other cancer has seen such a range of wider treatment and targeted therapies and immunotherapies as much as the lung cancer has seen. And hence we have to keep up as updated for all these treatment. And hence we will be having 4 talks. We will be discussing upon the EGFR mutant lung cancers, then the adjuvant treatment in the EGFR mutant lung cancer. We will have the molecular discussion as well as the overview of the lung cancer. So for the first talk, I will invite Dr. Kapil Goyal. He is consultant and unit head, Rajiv Gandhi Cancer Institute, Niti Bagh. He will be discussing about the decoding the treatment of EGFR mutant lung cancer. Good evening, Dr. Kapil.
Hello, sir. How are you? Good evening, sir.
Yes. Thank you so much for joining.
Yeah, my pleasure, sir. So, shall I start?
Yes, it's yours.
Oh. So, I hope my slides are visible to everyone and I'm audible.
Yes, Dr. Kapil, yes.
Okay. So, hello, good evening, everyone. So, it's my utmost pleasure to be discussing about lung cancer, specifically speaking about EGFR mutated NSCLC. And it is Dr. Manish already explained. Lung cancer, as we all know, is one of the most important cancers we are dealing with. So, I will be briefly discussing first about the worldwide data of all cancer. If you see, according to Globocan 2020 data, the female breast cancer was the most common cancer, that is 11.7%, very closely followed by lung cancer, which is 11.4%. And but if we look at the mortality chart, we see that lung cancer tops the chart here, causing 18% of mortality of all cancer. So more than its prevalence, lung cancer is more mortality causing cancer, and that is why the discussion and newer management of this cancer becomes important. So, in combined both sexes, lung cancer is the second most commonly diagnosed cancer just behind breast cancer, and it is a leading cause of cancer, causing 18% of the total cancer deaths. The parameter which determine the choice of first-line treatment in advanced EGFR mutated NSCLC patients. So, most important factor is progression-free survival. Whenever we are talking about metastatic cases, then progression-free survival is the first outcome that we see in any trial, followed by the gold standard overall survival. Apart from that, there are many important parameters like overall response rate, presence of brain metastasis, because many trials seem to exclude patients who have brain metastasis. Then we have to look at the safety and toxicity profile of the concerned drug. Then the quality of life, because many agents have so many side effects which hamper the quality of life of the patient and patient receiving subsequent therapy upon progression. So the crossover between therapy is very important, specifically speaking, when assessing for overall survival. So this is a rough graph which is showing the PFS improvement in with the TKIs in NSCLC, EGFR mutated NSCLC. So in 2000 decade, we used to have two drugs, which is Geftinib and Erlotinib. So the IPASS trial of Geftinib and Optimal and Ensure trial of Erlotinib. So they were the legendary landmark trial which showed that apart from chemotherapy, the first kind of targeted therapy was being applied in lung cancer, and it showed that Geftinib had a progression-free survival of 9.5 months, which was better than chemotherapy, and Erlotinib took it a notch further, bringing it to 13.1 months, which was even better. Then we had few second-generation TKI because of the adverse events of Erlotinib and Geftinib. So there were molecular selectivity was enhanced in those second-generation TKI, and we had two new molecules coming up like Afatinib and Dacomitinib. Lux Lung 7 trial of afatinib, which compared afatinib to the geftinib, gave a progression-free survival of 11 months, and dacomitinib gave a Archer 1050 trial of dacomitinib compared with geftinib got a PFS of 14.7 months. It is up to here that we were not able to cross beyond 1.5 years. Then first time osimertinib with this Flora trial came into the picture, which showed that the progression-free survival of up to 19 months can be reached, and it was truly landmark. If we look at the Kaplan-Meier survival curve and where the comparator arm, the curve starts separating at a different point of time. In Lux Lung 7, afatinib and geftinib, the curves were overlapping initially, and only after gap of 12 months they start separating. In the Archer 1050 trial, the curves started separating at 6 months, while in the Flora trial, the curve started separating almost immediately as per the follow-up. So the treatment effect was seen from the beginning itself. Talking about median PFS in the Lux Lung 7 trial, afatinib and geftinib, the median PFS were almost same, 11 months. The dacomitinib arm was slightly did better in 15 months versus 9.2 months with geftinib. However, if we see that was almost doubling of PFS with osimertinib in Flora trial, that is 19 months compared to 10.2 months in any of the erlotinib or geftinib on another TKI. Point to be noted that dacomitinib trial had excluded brain metastasis, while in the Lux Lung 7 trial and Flora trial, both included stable brain metastasis also, in which concluded 16 and 19% of the patients, respectively. Although their word of caution here, it is a cross-trial comparison, which is not a standard comparison, and we should not be doing like that. And there is no head-to-head comparative studies available which have compared osimertinib versus dacomitinib or osimertinib with afatinib. So, as we have already discussed, the early separation of PFS curve is shown by osimertinib only. If we look at the ORR, which is also a very important marker because it shows the percentage of patients who are having either partial response or complete response to the therapy. So in Lux Lung 7 trial, we see that the afatinib overall response rate was 70%, while it was 75% with the dacomitinib. And with osimertinib, it was 80% in Flora trial. If we talk about median duration of response, which was 10.1 months with afatinib versus 14.8 months in dacomitinib, and it was better. It was 17.2 months with osimertinib in Flora trial. So osimertinib has shown highest ORR and median duration of response. If we look at the overall survival curve, we see that the curves are separating nicely starting from the beginning itself, with the median OS of 38.6 months received with osimertinib compared with the EGFR TKI 31.8 months in the comparator arm with a hazard ratio of 0.79, which is statistically significant. Median OS for first time breached more than 3 years of median OS, which was remarkable. And osimertinib patients are more likely to be alive at second year and third year landmark. If we look at the 2-year OS, so that was 74% versus 59%. While we look at the 3-year landmark, it was 10% more patients were alive in the osimertinib arm. And it was the first time that EGFR TKI has translated a PFS into a significant OS benefit. Previously, none of the drugs had shown any clear-cut OS advantage. If we look at the Lux Lung 7 and Archer trial OS analysis curves, the afatinib and geftinib, there was no OS benefit. It was 24.5 months versus 27.9 months. So afatinib failed to show any kind of OS benefit. In Archer trial, the trial design was such that the hierarchical gatekeeping procedure was used. So first they said the PFS followed by ORR followed by OS. So only if ORR was significantly better, then only OS would be statistically tested, because they were failure to have a significant ORR benefit with osimertinib. Hence, overall survival was not calculated in a statistically significant manner. Although if we look at curve at the closely, then probably numerically speaking, median OS was improved with dacomitinib, which was 34 months compared with 27 months with geftinib. So, as we previously discussed, the phase 3 Archer trial excluded patients with brain metastasis, although it improved a numeric improvement in OS of 34.1 months with dacomitinib compared with 26.8 months for geftinib. However, because of the statistical significance limitation, the OS was not formally assessed. If we look at the Flora trial, so after 36 months, we see that 28% of the patients were still receiving osimertinib, which is a lot, and only 9% of the patient in the comparator arm were at the same drug. So at the time of data cutoff, 22% versus 5% of the patient were still on the treatment at data cutoff. If we look at the CNS profile, so this is where the things get even more interesting. So if we look at the patient who had CNS metastasis versus who do not have CNS metastasis, the efficacy and benefit of osimertinib was regardless. It was present in both the patients. As expected, the survival with patient who had known CNS metastasis, the median PFS of 15.2 months compared with 9.6 months, hazard ratio of 0.47. Although in patients who do not have any kind of CNS metastasis, the median PFS was even higher, that was 19 months versus 10.9 months. And the curves were separating nicely. And CNS progression event occurred in 6% of the patient receiving osimertinib, while it happened in 15% of the patient receiving standard of care EGFR TKI. If we look at the intracranial PFS analysis, then in these curves also we can see with the osimertinib and standard of care, the CNS PFS was not reached in the osimertinib arm compared with 13.9 months in the standard of care arm, and the hazard ratio was 0.48, which is statistically significant, and it was after a follow-up of 1 year. And so CNS PFS was also statistically significant with osimertinib versus comparator. If we look at the CNS response to first-line osimertinib in patient with EGFR mutated advanced NSCLC and CNS metastasis. So we have different data from different drugs like afatinib, dacomitinib, and osimertinib. In the Lung 7 trial of afatinib, we see that the response rate, CNS response rate, was not reported. In dacomitinib trial, the CNS metastases were excluded, while in the FLORA trial, we see the response rate was 66%, which is a lot. Comparatively, it was only 43% in the comparator arm, and the median CNS PFS was not reached versus 14 months, as I've already discussed. In afatinib arm, because they had included patient with CNS mets, the CNS PFS was 7.2 months, which was same as the geftinib arm, which was 7.4 months. So afatinib failed to show any benefit in CNS PFS, while osimertinib showed a significant benefit in CNS also. If we look at the safety profile, so if we look in the Archer 1050 trial of dacomitinib, dermatitis was a very significant problem, and 15% of the patient had grade 3 or 4 dermatitis, while diarrhea was also 8% of the patient had grade 3 or 4 diarrhea. Apart from that, the skin toxicity of maculopapular rash and pustular rash was also higher. If we look at the FLORA trial, only 2% of the patient had diarrhea, while only 1.4% patient had fatigue, which were grade 3 or 4. And overall, any kind of grade 3-4 adverse event with dacomitinib was reported in 63% of the patient in Archer trial. While talking about afatinib, 31% of the patient had grade 3 or 4. Compared to this, in osimertinib, only 18% of the patient had any kind of grade 3 or 4 adverse events. If we particularly talking about skin toxicity and diarrhea, we see that afatinib caused grade 3-4 diarrhea, skin toxicity in 9% of the patient. Dacomitinib caused in 14%, while it was less than 1% in with the osimertinib. Talking about diarrhea, it was 13% with afatinib, 8% with dacomitinib, while it was only 2% with the osimertinib. So dose reduction patterns were also favorable for osimertinib. In Lux 7 trial, almost 42% of the patient had to reduce the dose of afatinib, while only 2% dose reductions were required in the geftinib arm. In the Archer trial also, more than 2/3 of the patient had to interrupt their treatment, or the dose reduction was required because of the significant side effects. However, the dose interruption was required with osimertinib with only 5% of the patient. Hence, it was showing that osimertinib is a remarkably well-tolerated drug, and so has been the personal experiences of, I think, most of the medical oncology community, that the side effect profile of osimertinib is quite favorable, and very few patients need either dose reduction or treatment interruptions. Talking about the quality of life, if we see that in Archer trial, the global quality of life was maintained in the dacomitinib group and was significantly improved, but it was not considered a clinically meaningful improvement in the geftinib group. While in the FLORA trial, the global quality of life was improved from baseline in both osimertinib and EGFR TKI group, with no clinically relevant difference between two groups. Also, one third of all EGFR mutated patients treated with first or second generation EGFR TKI are able to receive second line osimertinib. It is a hypothesis which is postulated, but is it like that? So we have a real world data here where 10 patients of EGFR mutated patient who start with geftinib or erlotinib first line, and many of these patients die during first line or receive only palliative care upon progression. Approximately 75% of the patient are able to receive any kind of second line therapy. Out of this, which only up to 70% patient receive a valid T790M patient, which leaves only a few patients in the end. Many patients are not eligible for tissue biopsy, have insufficient tissue from biopsy or invalid test results. So hence the T790M mutation was not achieved. Out of the patient who get T1790M mutation, only 50% of the patient are actually T790M positive. Hence, the rest of them are negative. So if we begin with 10 patients, only 3 of patients are actually able to receive second line osimertinib. And 7 out of 10 patients who start on first or second generation EGFR TKI will not be able to receive osimertinib in the second line. And also, it is not possible to predict that which of the patient are there who will develop some kind of T790M resistance. So not all the patients, if we start on first line EGFR TKI, so not all patients will be able to derive the benefit from osimertinib. And access to second line therapy is also pretty restricted. If we see across all trial of first line, second line, or third line, like IPAS, EURTAC, optimal trial, ensure trial, in LL Lux Lung 7 trial, on all the trial, if we see the second, only two-thirds of the patient, ranging from the least was 51% and the highest was 88%. Only two-thirds to 75% of the patients are able to receive any kind of second line therapy. And standard of care TKI arm in FLORA, subsequent treatment, only 61% of the patient received. So the one third of the patient will not have access to second line treatment. Hence, the argument that the osimertinib can be provided in second line therapy is actually not possible for most of the patients. Then we have few real-world evidence of C190M mutation after afatinib. In Japanese study, 43% of the patient acquired T790M mutation after first-line afatinib. In a Taiwanese studies, 48% of the patient acquired T790M mutation after progression on afatinib, and in another study, it was done in 32% of the patients. So nearly 40 to 50% of the patient will actually develop T790M mutation, who will subsequently be eligible to receive osimertinib. And less than 50% of the patient put on afatinib acquired T790M mutation. Hence, it is very important that we sequence EGFR TKI in a way that maximum of patient derive benefit of osimertinib, that is in the first line. Hence, osimertinib should be started in the first line only. Starting with prior generation TGFR TKI and then treating those that develop EGFR T790M mutation with osimertinib, it is not optimal clinical care. Because first, we are not smart enough to figure out who will get EGFR mutation. Not everyone will be well enough to receive additional treatment. 30% of the patient do not receive any subsequent therapy. And further testing by tissue biopsy or liquid biopsy will not always be successful. And osimertinib is associated with a significant survival benefit as first-line therapy itself. Furthermore, there are many uncontrollable factors while we derive an optimal sequencing of drugs like toxicity to the drug, occurrence of T790M mutation, sites of progression, concurrent morbidity, and patient choice. Because many times patient also gets fed up with the cancer treatment and they may refuse to receive any kind of second line therapy. Then we have a few real world studies with first line osimertinib. Here we have a flower study, which is a first line osimertinib in real world, and it is an interregional prospective study in which Italian 9 center of Italy were taken, 126 patient data from June 2018 to September 2020. The first line metastatic or advanced EGFR mutated NSCLC patient were reviewed. All the patients were white with a median age of 68 years, and performance status was poorer than 2 in 13% of the patient. Remarkably, 30% of the patient had brain metastasis at baseline, and PS2 was also 13%. So hence we can, and comorbidity index more than 6 was there in 94% of the patients. So as to say, compared to the optimal trial design, the patient population in this study was actually worse. If we look at the time to treatment discontinuation, it was 25.3 months, and median time to treatment discontinuation in patient with or without symptomatic diagnosis, if we see, then time to discontinuation it was 18.8 months versus 21.4 months. with 3 metastatic sites. Progression-free survival was also 19 months, and median PFS in patient with or without brain metastasis at diagnosis. So progression-free survival with no brain metastasis was not reached, while in those with patients with brain metastasis was 13.3 months. And median PFS in patient who had versus who did not have any symptoms. The asymptomatic patient median PFS was not reached versus for 15.5 months in patient who had some kind of symptoms. So if we see that none of the patient acquired CR, while 73% patient acquired PR and 23% patient had stable disease, only 4% of the patient had primary refractory disease. So if we see the PFS and CNS PFS data was as good as the trial, while actually the patient population was worse. If we look at the safety data and conclusion, so in patient with recurrent disease, the median time from biopsy to pathological report was 7 days, and from pathological report to EGFR mutation status report was 8 days, and EGFR mutation status report to osimertinib start was 17 days. So overall, if we see, so approximately 1 month was wasted before the from the patient who comes to us and starting of the treatment. Upon patients who experience progressive disease, 47% patient underwent a rebiopsy, and the tissue rebiopsy were done in two-thirds of the cases, and liquid biopsy were done in only 1% of the case. Molecular analysis was performed in 13 samples, and druggable resistance mechanisms were found, in which the most common was MET amplification, and MET amplification and EGFR co-amplification. Most common adverse event were diarrhea, which was 39%, and skin rash 33%, which is a lot. And most common adverse event was venous thromboembolism, which was seen in 7%. However, you look at the diarrhea, the grade 3-4 diarrhea was present in only 3% of the patient, and skin rash was also present, grade 3-4, only 1.6%. Most of the side effects were only grade 1 or grade 2. And no difference in rates of DTE was reported according to the age, PS, comorbidity, or tumor load. And no difference in survival outcome was observed according to the age, comorbidity, and type of EGFR mutation. And so osimertinib conferred effectiveness and safety in the real world, although thromboembolism were probably more frequent than previously reported. Next, we had OSI FACT study, in which osimertinib as first-line treatment for advanced EGFR positive NSCLC in real world was seen in Japan. Patient population was larger, 538, in which the median PFS achieved was 20.5 months, and median TTF was 19.1 months, which is a lot. And ORR was 76%, while disease control rate was 94%, which is an excellent data. If we see, look at the toxicity, the pneumonitis of all grade was seen in 13% patient, while it was non-hematological toxicity was seen in 12% of the patient. Compared to FLORA trial here, the incidence of pneumonitis was higher, which was seen, and reason for treatment discontinuation was 44% because of the disease progression. Because of the 25.6% patient had because of the pneumonitis, and other event was 16%. So PFS after first-line osimertinib treatment was favorable, although the incidence of pneumonitis was higher, which needs further evaluation. Then we had MICNOS trial, which is a USA, Japan, Germany, and China trial, in which the sample size was 541 patients, in which the next real world time to next treatment or death, which is more realistic representation of osimertinib efficacy in real world, the median follow-up time was 9.6 months, and median RW, TT, and TD was 17.9 months, which is good, and RW TTD was 17.2 months, and 58% patient remain on first-line osimertinib therapy or were lost to follow-up. So the interim, these data support the effectiveness of osimertinib in the real-world population. Long-term outcomes are awaited. What do the guidelines say? So these are the NCCN guidelines updated. So in which we see that the osimertinib is in the category 1 recommendation in patients who have EGFR mutation discovered prior to first-line systemic therapy. It so happens that many a times patients is started on chemotherapy before getting the EGFR testing done. This may happen particularly in two situations. One, the chemotherapy is given in the peripheral centers where the testing facility is not there. Second, patient performance status or the disease burden is higher. So while we are waiting for our EGFR mutation report, we start on some kind of therapy. In those cases also, so the NCCN guidelines say that complete plant systemic therapy, including maintenance therapy, or you can interrupt chemotherapy and give osimertinib directly, which is a preferred approach. So, as per living guidelines, what do they say? So, patient with stage 4 NSCLC who has a non-squamous cell carcinoma or squamous cell carcinoma in non-smoker subset, you have any sensitizing L858R or exon 19 deletion mutation, you give osimertinib monotherapy. It is a strong strength of the recommendation, followed by moderate recommendation or weaker recommendation by geftinib with chemotherapy, dapometinib, and so on other. To summarize, osimertinib is the only EGFR TKI which has demonstrated a clinically and statistically significant improvement in the overall survival. The median OS benefit of greater than 3 years sets a new benchmark for osimertinib and provides a window of opportunity for the management of patients with stage 4 NSCLC. Flora is the first time an EGFR TKI has shown an OS benefit over PFS benefit. Nearly 30% of the patient remain on osimertinib at 3 years, and it is the only drug which can be given in patients with brain metastasis and SEPT790M mutation. And osimertinib is the safest and the least toxic drug among all the available options. Sequencing cannot be considered the best strategy as almost 70% patients are not eligible to receive osimertinib in the second line as demonstrated earlier. Out of 10 patients, only 3 patients are actually able to receive osimertinib in the second line. These data confirm osimertinib as the first-line standard of care in metastatic EGFR mutated NSCLC. So these slides were provided by AstraZeneca. Thank you.
Thank you, Dr. Kapil.
Yeah, I'll be happy to take any questions.
Thank you, Dr. Kapil. I am audible?
Yeah, sure. Yes, sir, you are audible, sir.
So, it was very elaborative presentation, and you decoded the treatment very well. So any experience with chemotherapy plus gefitinib, or we now have newer data with FLORA-2,
Flora-2, right?
which gives chemotherapy plus osimertinib, and then the PFS is 25 months. So it is almost 7-8 months more than what we see in FLORA. So what is your take on FLORA-2 trial? And for those patients who are not affordable to osimertinib, what is your take on pemetrexed plus gefitinib?
So, sir, so my treatment as of now, if tomorrow some patient comes to me in OPD, so my treatment option will be first, I will give osimertinib plus chemotherapy, the FLORA-2 trial. If that is not the option, maybe because of the PS, then I give osimertinib monotherapy. But if the osimertinib financial is the main issue, then geftinib plus chemotherapy. That was the NEJ, the Japanese trial, which showed the geftinib, and there was one Indian trial also, probably from Tata Memorial, which showed that geftinib plus chemotherapy. So that is my treatment approaches. So osimertinib is still quite expensive. Not many patients are able to take it.
So are you okay with osimertinib plus chemotherapy? So I read that paper, and there were many
Yes, sir. Yes, sir. Although I'm not, the detailed paper is still awaited, but I feel that OS data is still not there. But with the PFS benefit advantage being so much, almost, it's a lot significant, numerically speaking also. So I'm very much convinced that it is probably the best option and will be in the guidelines within next few months.
So would you not like to keep osimertinib as first line and then chemotherapy sequencing? Chemotherapy sequence would also give you 5 months survival benefit. Not exposing the patient to first line chemotherapy only when the oral treatment is available.
So, sir, the PFS benefit has already been demonstrated. So, I believe in the metastatic disease, we are often, obviously, we are focusing on OS, but PFS is also very important. It's a very important marker because it is concerning with if we look at the financial toxicity and the emotional burden. So, I think the PFS is also very important. The patient does not have to deal with the trauma of having disease not working. Moreover, by the time patient progresses, many of the patient had deterioration in PS. So by that time, actually, or the metastatic burden may be too high. So at that time, I feel when the patient comes to us, that is the best opportunity to use chemotherapy, specifically if the data supports that.
I agree, because once the patient goes to the second line, almost 1/3 of the patient, they will be just for the palliative care, and they will not be
Definitely. The palliative care, financial exhaustion of all the funds, that issue, PS, morally also, some patients do not want to, they're fed up, they don't want to take treatment also. Those issues also we need to take.
Secondly, we also have the data from INSIGHT study, which says that almost 33% patient will develop MET amplification as a resistance mechanism. And in that case also, we can use osimertinib plus MET inhibitor and then go on to the chemotherapy. So I think that would be the right approach. Thank you so much for the presentation. Thank you so much, Dr. Kapil. The next presentation is by me, and I will be speaking on the ADORA trial, that is osimertinib in the adjuvant clinical setting. Can I share my slides? Dr. Kapil, you have stopped sharing, na?
Sir, please start
Yes, sir,
sharing
I've
now.
stopped.
Thank you.
Yes.
So let's move on to the adjuvant setting, which is osimertinib in early EGFR mutant NSCLC patients in the ADORA trial. So 1 in 3 patients with NSCLC, they will present with resectable disease. And these are the patients who will be having the adjuvant osimertinib as a treatment. So lung cancer is the leading cause of the cancer-related death, and it accounts for more than 1.7 million deaths annually. As many as the deaths as breast cancer, prostate cancer, and colorectal combined together. So this is the most common cause of cancer which causes the death. NSCLC represents approximately 85% of the lung cancer cases, with an estimated 30% of the patient presenting with the resectable disease at the diagnosis. So localized disease or early stage disease is stage 1B, and locoregional disease is stage 2 and stage 3A. Here is the role of surgery for our patients. So outcome in the early stage disease needs to be improved. We know that in the adjuvant setting, we only have chemotherapy as the adjuvant treatment, or radiation as the adjuvant treatment after surgery, and most patients will have the disease-free survival of increase in median disease-free survival of 5 to 7 months. The surgery is the primary treatment for all the patients with early stage NSCLC, and adjuvant cisplatin is recommended for the patient who have staged as stage 2 to 3A NSCLC, and select patients with stage 1B. So results from the large randomized trial and meta-analysis shows that 5-year overall survival with the adjuvant chemotherapy in the patient with early stage NSCLC. DFS also favored adjuvant chemotherapy, and I would like you to remember the hazard ratios which are present here. It is just 0.89, and here for the DFS, the hazard ratio is 0.84. Please do remember this hazard ratio, because we will be discussing upon the hazard ratios of the ADORA trial. And the overall disease recurrence following the surgery and adjuvant treatment remains high across the stages. So you can see that even with the very early stage disease, stage 1B, 5-year recurrence by stage is around 45%. And as we go on the stage 3, the 5-year recurrence is around 75%. So only 25% patient will be left without disease at if they have stage 3 disease at the diagnosis. So based upon the limited number of the study, the prevalence of EGFR mutation, it broadly appears similar across the disease stages. And you can see that this slide is here because we know that the EGFR mutations, they are present in approximately 25 to 40% patients in Asians, and in Caucasians, it is 10 to 20%. And here in the early stages also, if the data has been dissected, and you can see in Asia, US or Europe, the data is almost similar, or in fact, much higher EGFR mutations are present in stage 1, stage 2, or stage 3. So if EGFR TKI were available in the resectable disease setting, a similar proportion of the patient will be able to get the benefit of the treatment in the advanced setting. So coming on to the osimertinib as adjuvant treatment, the data from the ADORA trial with this small background. This was a phase 3 double-blind study design. And the patients with completely resected stage 1B, 2, 3A, or NSCLC with or without adjuvant treatment were included, and the inclusion criteria were more than 18 years of age, WHO performance status of 0 to 1, confirmed primary non-squamous NSCLC, that is adenocarcinoma, with exon 19 deletion or L858R mutation, with brain imaging not showing anything, with complete resection with the negative margin. And the maximum interval between the surgery and randomization was 10 weeks without adjuvant chemotherapy and 26 weeks with adjuvant chemotherapy. So stratification factors were stage, EGFR mutation, and race. And these patients, they were randomized in 1:1 fashion to osimertinib 80 milligram once a day or placebo. Approximately the number of patients, they were 682. And the planned treatment duration was 3 years. Treatment continued until disease recurrence, completion of the treatment, and discontinuation criteria met. Follow-up was until recurrence, week 12, week 24, and then every 24 weeks to 5 years, and then yearly. So primary endpoint was DFS by investigator assessment in stage 2, 3A patients. This was designed for superiority under assumed DFS of hazard ratio of 0.70. And the secondary DFS in the secondary endpoint was DFS in the overall population, with DFS at 2, 3, 4, and 5 years. So, following the IDMC guidelines recommendation, the study was unblinded early due to efficacy. The drug was found to be very efficacious, and hence the study was unblinded early. And here we report an unplanned interim analysis. And at the time of unblinding, the study had completed enrollment, and all the patients were followed up for at least 1 year. So these were the inclusion criteria: adults more than 18 years of age, primary non-squamous NSCLC, post-operatively staged as stage 1B to stage 3A, central confirmation by laboratory to have exon 19 deletion or L858R mutation, and standard post-operative adjuvant chemotherapy consisting of platinum-based doublet, that is 4-cycle maximum. They were but non-mandatory, and the complete surgical resection should have been done. MRI or CT scan prior to the surgery should be done. And these were the exclusion criteria: any kind of pre or post-operative radiotherapy, any pre-operative chemotherapy. So NACT with chemotherapy was not allowed. EGFR TKI prior if had been given, then CYP3A4 inhibitor in the past less than 3 weeks. And time between the surgery and randomization should not have been more than 10 weeks if no adjuvant treatment was used, and 26 weeks if the adjuvant treatment was used. Patient who have only segmentectomy or wedge resection, they were also excluded. So coming on to the baseline clinical characteristics, demographics of the ADURA trial, they were generally well balanced between the treatment arm, and the proportion of these stages was similar when ADURA patients, they were staged by AJCC or UICC 8th edition. So 32% males and 68% females. Average age was 64 years, median age. Most of the patients, they were non-smoker. 32% were smoker and 68% they were non-smoker. Asians represented 64% patients. Performance status was 0 to 1 in almost all the patients. Histologically, adenocarcinoma, 96% patients. EGFR mutation at randomization with exon deletion represented in 55% patient, and L858R represented in 45% patient. 60% patient received chemotherapy, while 40% patients did not receive chemotherapy. And this is the updated primary analysis in the stage 2/3A. And you can see that median DFS for osimertinib is 65.8 months versus placebo, which is 21.9 months. So there is wide separation of the curve, and you can see that the separation starts very early. And you can see here the hazard ratios. Hazard ratios is just 0.23. We remember that the hazard ratios in the adjuvant chemotherapy trials, they were 0.89 or 0.84, something like that. So hazard ratio is very impressive over here. This is updated primary analysis in the overall population. Here also the curves, they separate early. Osimertinib had the median DFS of 65.8 months versus placebo, which is 28.1 month, and the hazard ratio is 0.27. So this is 4-year DFS was consistent for osimertinib arm across the disease stages. For 1B, the 4-year DFS was 80%. For osimertinib, for stage 2, it was 74%, and for stage 3A, it was 65%. So whereas we remember that 5-year DFS, 5-year overall survival, in fact, with the chemotherapy as the adjuvant treatment was 25% just in stage 3A. And you can see that the hazards ratios for these DFS were 0.41 in 1B, 0.34 in stage 2, and 0.20 in stage 3A. And there was no subset in which the treatment did not work well, irrespective of age, sex, or smoking status, race, irrespective of the stage, and irrespective of EGFR mutation, and irrespective of chemotherapy. So you can see that in all of them, the hazard ratios, they are between 0.2 to 0.3. And this is the early snapshot of the overall survival in the patients with stage 2 and stage 3A. In both of them, the median OS has still not been reported, and the patients and investigators remain blinded to the treatment in order to facilitate the assessment of OS at maturity. So the EGFR TKI in the adjuvant EGFR NSCLC setting, earlier also there were many study, and DFS was there, but OS benefit has not been demonstrated by any of the EGFR TKI. So the erlotinib in the SELECT study with 100 patients, RADIANT study with erlotinib with 973 patients, then IVAN study with erlotinib, adjuvant CTONG 1104 study with adjuvant gefitinib, and BR19 study with adjuvant gefitinib. So all of them, they had shown some kind of disease-free survival advantage, except for gefitinib in BR19, which did not show any disease-free survival. But the overall survival benefit was not present in any of these studies. The type of the recurrence is the key consideration in the resected NSCLC, whether the recurrence happens at the local or regional site, longer post-operative recurrence period. So the CNS is the most common site for recurrence in the EGFR, distant recurrence in the EGFR mutant NSCLC. And we know that for EGFR mutant NSCLC, the brain is sometimes a sanctuary site, and most of the patient, they will have brain as a distant metastasis. In adjuvant RADIANT study, 37% of the recurrences in EGFR mutant NSCLC with erlotinib had CNS involvement. So 37% patient with erlotinib had CNS involvement in adjuvant RADIANT study. And the osimertinib has been shown to greatly achieve a significant exposure in brain compared to the other EGFR TKI, and has shown greater penetration of blood-brain barrier. In the advanced NSCLC setting, first-line osimertinib demonstrated superior overall survival and a 52% reduction in the risk of CNS progression compared with the erlotinib and gefitinib. And these are the type of disease recurrences. You can see that 11% of the patients in the osimertinib arm had DFS events versus 46% patients in the placebo. And in osimertinib arm, the majority of the patients they had local or regional recurrences only, and with only 38% patient having metastasis recurrence compared with 61% patient in the placebo arm. We can see here in the diagram what we have said. So 11% had the disease progression recurrence in osimertinib arm, while 38% in the placebo arm. And the distance recurrences, they are quite low in the osimertinib arm. And these are the sites of distant recurrences in the patients. You can see that the local recurrence, that is lung, lymph node, they were more common in the osimertinib arm, while the distant recurrences such as liver, pleural effusion, adrenal gland involvement, head and neck involvement, liver involvement, pleura involvement, it was more common in the placebo arm. The most common first site of recurrence were lung, that is 12%, lymph node 6%, and CNS is just 6%. You can see that it was 11% here in the placebo, while it is just 6% here in the CNS arm. Sorry, in the osimertinib. And this is updated CNS DFS event in stage 2, 3 A disease. So the overall 63 patients, 14% patient were on the treatment at the time of CNS recurrence with osimertinib versus 29% with the placebo. In both of them, the DFS, CNS DFS has still not been achieved. Coming on to the safety summary, so no new safety signal have been identified, and the usual side effects which we expect with osimertinib, they are there, but you can see that they are more in number. They are more in number because the disease, the duration of exposure is longer. While the one side of the patient, they are receiving 3 years of osimertinib versus none of the patient receiving osimertinib in the other arm, and hence the number of side effects are also more. So what are the all-cause adverse events? They were diarrhea, paronychia, dry skin, pruritus, cough, stomatitis, and URTI, which were most common, and others were nasopharyngitis, decreased appetite, dermatitis, acneiform, mouth ulceration, weight decrease, and arthralgia. Interstitial lung disease was reported in 11 patients, that is 3% patient, and QTc prolongation was reported in 9% patient with the osimertinib arm. So this is the adjuvant chemotherapy use. Overall, 60% of the patient, they had received adjuvant chemotherapy for median duration of 4 cycles. The majority of the patients received platinum-based chemotherapy, most with stage 2A and stage 3A, and fewer with the 1B stage. And the adjuvant chemotherapy use were more frequent in the patients aged less than 70 years and in patient enrolled in Asia, and was not influenced by the PS of the patients. So stage 1B, 26% patient received adjuvant chemotherapy, stage 2, 71%, and stage 3, 80%. And you can see that in DFS in the patients with or without adjuvant chemotherapy, it is the hazard ratios are favoring the osimertinib. Similarly, the DFS in the patient with or without chemotherapy, here you can see that all the hazards, they are favoring osimertinib in the clinical trial. This is DFS in the patients with or without chemotherapy in stage 1B, stage 2, and stage 3A. Maximum benefit is in stage 3A. Coming on to the patient-reported outcomes from ADURA trial. So the quality of life, the health survey was SF36, and the data collection was done in all the patients till week 24, and every first in the at the randomization, then at week 12, then week 24, and then every 24 weeks the quality of life data was taken, and you can see that in compliance with the SF36 health survey over time, the compliance rates with SF36 were high in both osimertinib arm and the placebo. Time to deterioration of the physical and mental component, it was similar, and it was in fact better with osimertinib as compared to the placebo. So in this updated DFS analysis of osimertinib versus placebo, the patients have been followed for a further 2 years and had all the opportunity to complete 3 years of the planned study treatment. And the overall, there was 77% risk reduction of the disease, recurrence, or death in the adjuvant osimertinib versus placebo, the hazard ratio being 0.23, and in the stage 2A, 2 and 3A. And the median DFS was 65.8 months with osimertinib and 21.9 months in the placebo arm. So there was also a 73% reduction in the risk of disease recurrence or death with adjuvant osimertinib versus placebo, and an improvement in DFS was seen regardless of whether patients received prior chemotherapy or not. DFS benefit was seen across the stage following these stages based upon the AJCC 8th edition manual, and the osimertinib demonstrated clinically meaningful CNS DFS as well. Thank you so much for your patient listening. If there are any questions, we can take. So if there are no questions, we can move on to the next session. Dr. Praveen is here. Dr. Praveen?
Sir, Dr. Praveen is here, but he is mute.
We will ask him to unmute.
Yes, sir, just a minute.
Garima?
Yes, sir. Sir, Dr. Praveen is joining, sir.
Okay. So, Dr. Praveen is just joining. I think he had some technical issue. Uh, he was there at the moment.
Yes, sir.
I think Dr. Praveen has joined.
So, hi, Dr. Manish. I'm very sorry. So, I was traveling. Let me just. Uh,
Good evening, Dr. Praveen.
yeah, good evening, Dr. Manish.
So, we can start the session.
Yes, I think we can. Just give me a second. Ah,
So, Dr. Praveen
so,
is the senior consultant and head in Akash Healthcare in Medical Oncology Department, and he will be speaking on the overview of lung cancers. Over to you, Dr. Praveen.
thank you, Dr. Manish. Let me share the screen. So, I hope my screen is visible.
Yes, yes, yes.
Okay. So, good evening, everyone. So, I'll be speaking on Like I'll be talking about the overview of lung cancer, and we will be discussing various aspects of lung cancer. And we know that as per Globocan 2020, if we see particularly in India, so it is fourth most common cancer if we combine both the sexes together. But if we look at the males, so it is the second most common cause of cancer in India. So looking at the new cases, we can see over here that it amounts to almost 72,000 new cases every year, and it also is leading to 66,000 deaths per year. So this is the staging which we are following. So previously we were following AJCC 7, and now we are following AJCC 8, and there are certain changes. We are all aware of it. So because this, one second, please. So because this change happened in 2015, 2016, so we are very well aware of it. So one change was that T2B, it was converted to T3, and it was classified as those more than 5 centimeter of tumor. Initially, they were they 5 to 7 they were reported with the T2, and now 5 to 7 is reported as a T3 lesion. And on the basis of size, previously it was there till T3 only, and all tumor more than 10 centimeters or more than 7 centimeters, they used to be classified as T3. So now they are classified as T4. So these are investigative tools for staging of lung cancer. So bronchoscopy, so it is just for the sake of taking the biopsy and to look for the endobronchial component of it. CT chest, it is for the intrathoracic or the thoracic staging per se. So it is the gold standard to look at the primary tumor as well as the nodal status. PET-CT is for the distant metastasis, and it has better sensitivity and specificity as far as distant metastasis is concerned, and combining CT chest along with the PET component, so it definitely has complementary effect. And the nodal staging, the mediastinal nodal staging also is done in a better state with combination of PET and CT. So whenever we go for any surgical method or a local treatment. So we always tend to do the EBUS or EUS guided mediastinal staging. So it is gold standard in all except in stage 1A disease. Then mediastinoscopy, if there are some areas, so like prevascular node is there or so which are not accessible by EBUS or EUS, then mediastinoscopy should be performed. MRI brain is again for the staging of brain, and it is also done in almost all lung cancer where we are going ahead with the local therapy, except in those tumors which are less than 2 centimeter peripheral tumors. So regarding the CT chest versus PET-CT scan for staging in stage 3 non-small cell lung cancer. So those lymph nodes which are more than 10 millimeter, so they are predictor of malignancy, and we are looking at the short axis of the lymph nodes. CT scan is having a low sensitivity of 55% and low specificity of 81%, and it may help in selecting appropriate procedures for tissue sampling by providing the images. So as we were talking about, like if we add PET to the CT, so it improves the overall sensitivity and specificity to 80 to 90%. So the gold standard is still CT chest, or if we can add PET to the CT component, so then it is the gold standard. So one second. So sorry. Uh, So these are certain risk factors for occult N2 status. So like those patient occult N2 means that clinically when we do the imaging part, so we do not have any mediastinal lymph nodes which are involved. So but when we do pathological evaluation of these lymph nodes, so we have uh, involvement of mediastinal lymph nodes. So these are certain factors like if the tumor is centrally located, then the size of the tumor and the higher SUV on PET. So these are certain factors which says that presence of these factors, so more chances of occult N2 is going to be there. And similar was seen in this study by Lee et al., where they looked at the centrally located tumor or peripherally located tumor, and according to the clinical tumor size, so it was seen that the percentage of occult N2 metastasis, so those were more with the centrally located tumor, and when we fixed it for the tumor size, so those who have more than 2 centimeter size, so there it was more common. So regarding the mediastinal staging, previously or traditionally, mediastinoscopy was the gold standard, and there were a lot of studies which were done with the mediastinoscopy, and it can be performed with the conventional surgical method, then VAMLA, then TAMLA, then VATS. So it is quite invasive, and if we see recently we had analysis which showed almost equal concordance or equal positive predictive value of US EBUS by guided needle aspiration of the lymph node and mediastinal staging. So it is seen that US or EBUS in a good hand, in experts' hand. So it is almost equivalent to mediastinoscopy as far as the pathological staging of the mediastinum is concerned. So these are the lymph nodes, and most of the lymph nodes, so they are accessible by the combination of EBUS or EUS, except the prevascular lymph node and the aortopulmonary zone lymph nodes. And those lymph nodes which are below the carina, that means the level 8, level 9 lymph nodes. So they are not accessible, and here the mediastinoscopy is a better modality as compared to EBUS-EUS. So the question is, when is invasive mediastinal staging indicated? So we know centrally located tumor, all tumor we have to undergo, we have to go for mediastinal staging. So in peripherally located tumor, if the size of the tumor is more than 3 centimeter and some says more than 2 centimeters, so then we have to go ahead with the mediastinal staging. If there is extensive infiltration of mediastinum with no evidence of extrathoracic disease or positive N1, so then also we have to go. So if there is bulky N2 on CT scan, so there is no need for invasive confirmation. We take it as positive. Then discrete N2, yes, regardless of the PET-CT scan result. And if there is normal mediastinum on CT but positive on PET, yes. And if it is negative on PET, so there are few studies which says that we can omit it, but we have to take it with a pinch of salt, because the guidelines still suggest that we have to do the mediastinal staging for these patients. So this is the algorithm for mediastinal staging: PET-CT with intrathoracic lung cancer with or without enlarged lymph node. If the mediastinal lymph nodes, they are negative, clinically N0 and low probability of unforeseen N2 disease after negative PET-CT scan, directly we can go ahead with the curative treatment. If there is clinically positive N1 or clinically node negative and high probability of unforeseen N2, uh, even with the PET-CT scan being negative, so invasive mediastinal lymph node staging has to be done. So if the mediastinal lymph nodes, they are positive on imaging, so then we have to look at if there is mediastinal infiltration or is there is a bulky disease. So there is no confirmation which is needed. So we take it as positive. And rest of the lymph node, we do have to undergo the mediastinal lymph node staging. And depending on the result, we can go ahead and manage the patient. So these are the lymph node station accessibility. As we discussed that the prevascular, which is the 3 lymph node station, then 5 and 6, and the infracarinal lymph node, which are 8 and 9. So these are not accessible with the EBUS. EOS can access 8 and 9, but again 3, 5, and 6, it is a matter of concern as far as EOS is concerned. So then the dictum is that if you combine EBUS with EOS, so there will be staging which will be done for all group of lymph nodes except station 3A, 5, and 6. So if we see the mediastinoscopy, we are able to pick up the level 5 and 6 lymph nodes. But station 3, again, it is a difficult area and we are not able to pick it up with even with the mediastinoscopy. So if we go for VATS, so left-sided VATS can look at the left-sided lymph nodes, and right-sided VATS can we can do with the right VATS can look at the right-sided lymph node. Then TAMLA, it is able to pick up all the lymph node in the mediastinum, but it cannot target those lymph node in the thoracic or the 11R11 and then later lymph nodes. So these are again, this table is showing the sensitivity of various non-invasive and invasive staging modality. We can see over here that the CT scan is 55%, PET CT scan is 80%, EBUS, EUS, so they are highly sensitive, 89%. And if we see the combination of EBUS plus EUS, it is 91%, and EBUS US plus mediastinoscopy is 94%. So there is little increment when we are adding EBUS, US to EBUS or US plus mediastinoscopy to EBUS. I think EBUS is something, EBUS or US taken as a single modality. So it is something which is more than enough. And whenever you do a EBUS or US, you have to start the aspiration from the highest level of lymph node, so which are classified as the N3 lymph node. Like suppose if you are doing the uh, mediastin, this EBUS for right-sided tumors, so then you start with the left paratracheal lymph node or left hilar lymph node, and then you go further to the N2 lymph node and then to the N1 lymph nodes. So coming to evolution of therapy in lung cancer, non-small cell lung cancer, it was once considered a single disease, and it used to be treated with surgery followed by, or if a metastatic disease is there, then we used to treat with the histology specific treatment. Previously for the small cell, non-small cell, then histologic specific, then molecular pathology specific, where we were only having three oncogenes which were looked at, EGFR, AL cross, and after that the treatment has been categorized into two broad categories. So one is the oncogene driven and one is non-oncogene driven. Again, further non-oncogene driven tumor, they are classified as per the PDL1 expression levels, and the three categories are made. So those are PDL1 negative, those are PDL1 high expressors, and the others. So which was in the 1 to 49 percent category of PDL1. And the other way of classifying these is that according to the TMB, where it is more than equal to 10 mutation per MB or less than 10 mutation per MB. And it is seen that there was a time when the overall survival of non-small cell lung cancer with treatment, it used to be 6 to 8 months only, and now we have moved forward, and we have seen tremendous amount of improvement as far as the overall survival for lung cancer is concerned. And these are various therapies which have been approved over a period of last 15 to 20 years. And we have seen that there were a lot of targeted therapies which have been approved for various oncogenes which have been targeted. And apart from that, even for non-oncogene driven tumor, addition of immunotherapy to chemotherapy, so it has improved the outcome to a great extent. So these are the molecular targets, and we have almost 12 molecular targets, which are targetable in lung cancer, so including the KRAS G12C, an EGFR mutation, ALK fusion, ROS fusion, RET fusion, NTRK fusion, HER2 fusion or HER2 mutation, BRAF mutation, then MET exon 14 skipping mutation. So these are the molecular targets which are targetable or which are druggable. So, regarding the guidelines on neoadjuvant and adjuvant chemotherapy, depending on the disease stage and finding during surgery, so we have seen that stage 1A, where there is no lymph node involvement, so there is no role of neoadjuvant or adjuvant therapy. Stage 1B to 2A, so only in those patients who have more than 4 centimeter of tumor, so they should be given adjuvant chemotherapy. There is no role of neoadjuvant chemotherapy. Stage 2B onwards, there is role of adjuvant chemotherapy, and recently neoadjuvant immunotherapy has been tried for stage 3 disease, and it has shown a great amount of improvement as far as the major pathological response or the path CR rates are concerned, and but it is still to be validated whether the PPAT CR which is achieved or major pathological response which is achieved with the combination of chemoimmunotherapy that is whether translated to the overall survival advantage or not. So, whenever we have a, surgical specimen, so we have to look at the margin status, we have to look at the response to the chemotherapy, and the most critical point is the margin. So those tumor which have negative margins or no residual tumor by microscopic or macroscopic means, so it is termed as complete resection or R0 resection. Positive margins in form of microscopic residual margin, so it is termed as R1, and macroscopic residual, so it is termed as R2. And in any stage of the disease, if there is a R2 resection or a positive macroscopic margin, so it is always considered as a poor surgery, and here the surgery should be repeated and resection should be considered. But if the patient is not amenable or feasible for resection, then addition of RT can be given. But these patients, they have poor outcome even after giving the RT. So it is seen that those patients who undergo the curative intent treatments, 50% of them they relapse within 5 years time point, and the therapy is chosen according to the status of whether it was a local recurrence or a distant metastasis. So the latest ESMO guidelines recommended that adjuvant chemotherapy can be considered in those with high risk stage 1B disease, and it is seen in this walk trial, so which showed that in these particular tumors, so there was overall survival advantage with a hazard ratio of 0.66. So this was a LACE meta-analysis where it was seen that 5 trials, so the results were pooled, and that made the total amount of patient to more than 4,500. And vinorelbine cisplatin, that was the most commonly chosen regime in most of the trials, and it showed that the overall survival advantage was seen with the adjuvant chemotherapy with a hazard ratio of 0.89, and that translated to the absolute overall survival advantage of 3.9% at 3 years and 5.4% at 5 years. So this is regarding the adjuvant versus neoadjuvant strategy. So it is seen that the amount of benefit which was seen with the neoadjuvant or adjuvant strategy, that was almost equivalent, and whether chemotherapy is being used in the neoadjuvant setting or adjuvant setting doesn't make any difference. So now, after adjuvant chemotherapy, adjuvant targeted therapy is also being tried, and the most studied area is the EGFR mutation landscape. And we can see the ADAURA trial, so where osimertinib was used as an adjuvant targeted therapy. and in EGFR mutated population. And so this was continued for 3 years, and we can see over here that at 36 months, so there was a huge amount of improvement with a hazard ratio of 0.2 in favor of osimertinib when the disease-free survival was studied. We can see the graph separated early on, and there was a huge, very wide separation of graph, which was persistent throughout the time frame. And we can see that the DFS is improved for from 44% in placebo to 90% in the EGFR TKI arm at 24 months. So regarding the adjuvant immunotherapy, atezolizumab has been tried and it showed an improvement in survival in those patients who had PDL1 of more than 1%. And there are a lot of trials which are being considered in this treatment setting. And from here only, the trials were also started in the neoadjuvant setting. So regarding the radiation update in 2022, so it is seen that the advanced technologies or the latest therapeutic modality in radiation, they have led to safer treatment and more doses they are being given. IMRT has been shown to improve survival for patients with stage 3 non-small cell lung cancer and T3 T4 tumor, and it has somehow managed to reduce dose to the heart with lower rate of grade more than equal to 3 pneumonitis. So there is it is very important to differentiate between stereotactic body radiation therapy with conventionally fractionated EBRT, which for stage 3 non-small cell lung cancer is typically IMRT technique. So SBRT is high dose per fraction, and typically it is given in 1 to 5 fraction with 3D target localization. And it is used in early stage lung cancer, but due to concern for toxicity, not standardly used for large tumor more than 5 centimeter with N2 nodes. So coming to the 4D CT planning, so it basically allows for margins around the tumor to be minimized, and in this way it usually reduce the dosage to the heart and to the organs at risk. Coming to the IGRT, it ensures accurate target coverage for every treatment while reducing margins needed to cover the tumor. Adaptive radiation is like creating a new radiation plan after tumor target volumes have reduced in size, and it allows for normal tissue sparing. And the end result is that smaller target volume is there with lower doses to normal tissues like lung, esophagus, and heart. So, so these were the therapeutic aspect of radiation techniques, and this RTOG 0617 trial, it showed that in a stage 3 non-small cell lung cancer, 60 gray versus 74 gray. So what they had evaluated was that the standard dose versus the high dose CRT. The standard dose used to be 60 gray, and the high dose CRT was 74 gray. And it was seen that 5-year OS of 32% with high quality standard dose RT. It was seen with the prescribed radiotherapy schedule. And now even better results when immunotherapy is added to CRT backbones as per the Pacific trial. So it is seen. So stage 3 NSCLC, it has become a potentially curable disease, and the outcomes they have improved with incorporation of better radiation techniques and better systemic treatment. Hmm. So chemotherapy with or without radiotherapy, it is standard of care after complete resection of patients with stage 3 non-small cell lung cancer. And it is seen after the availability of lung art trial that if pre-operatively there was no N2 and in post-surgery N2 status is there, so there is no real advantage of adding adjuvant RT to the to the treatment regimen, and only chemotherapy should be used for these patients. So this is the specific trial where the checkpoint inhibition has moved to the early stage unresectable stage 3 non-small cell lung cancer. And it was a post radiotherapy setting. So where conventionally we were using nothing and the placebo was the only answer. And using durvalumab in that particular setting, it had led to improvement in the overall survival. And we can see that almost 42.9% of the patient, they were still alive at 5 years, as compared to 33.4% when durvalumab was not used. And so there was almost 10% improvement, absolute improvement with addition of durvalumab. And mind it that we are giving adjuvant chemotherapy at a absolute advantage of 4% only. So durvalumab definitely has improved the outcome of a subgroup of patients who otherwise also have poor outcomes, because these are more advanced patients where the chemoradiotherapy is being chosen. So targeted therapy, immunotherapy, we have already spoken about. Flora led to approval of osimertinib. Alex led to approval of alectinib in a subset of ALK rearranged non-small cell lung cancer. So MET exon 14 alteration or MET amplification. So crizotinib is approved, and recently capmatinib also has been approved for the same this RET rearrangements, cabozantinib, vandetanib, LOXO 292. So these are the drugs which are approved. NTRK rearrangements. So these are uncommon, but these are subgroup of patient who get a very good response rate and a very good overall survival if NTRK inhibitors are used, so like larotrectinib and entrectinib. HER2 mutation. So recently there was Destiny lung trial which was reported, and it led to improvement of these patient, improvement of outcome of these patient when TDXD was used, but otherwise also TDM1 can be used in this subgroup of patient. So we can see over here, it is a very good table which is summarizing the outcome with all subset of patients. So historically, if we see non-squamous and squamous histology, so platinum doublet, the median overall survival used to be 8 months. With the histology specific treatment with the addition of bevacizumab, non-squamous, it turned out to be 12 months. And with the maintenance pemetrexate, we improved the overall survival to 14 months. So if patient is having any of these targeted, druggable targeted oncogene mechanism, so we are able to get the patient to more than 3 years timeline in most of this. Immunotherapy, again, the mechanism of immunotherapy we already know, and there had been a lot of immune checkpoint inhibitors which have been approved for these patients. So in PDL1, TPS more than 50%, Pembro and Atezo, they are approved in patients with PDL1 and more than 1%, Pembro, Atezo, Nivo plus EP, all three are approved. Pembro and Atezo with combination chemotherapy is approved. So this is according to the immunotherapy based on histology. So non-squamous histology with chemo pembro. So the median OS is 22 months. With squamous histology with chemo IO combination, it is 17 months. If we particularly look at the PDL1 status, PDL1 more than 50, pembro 30 months, median OS. Atezo 20 months. PDL1 more than 1%, pembro is 17 months, and Nivo EP is 17 months. So immunotherapy, it has definitely made a very big impact on the outcome of these patients. So the checkpoint inhibition is moving to early stage of disease, which we have already discussed about. So on the basis of Keynote 091 trial, where pembrolizumab is being tried in the adjuvant setting, then durvalumab in BR31 trial, Nivo in Anvil trial, atezolizumab has already been approved in according to the IMpower trial. So the new in non-small cell lung cancer is the antibody drug conjugate. So one is TDXD and the other is datopotamab, which has come. Sexituzumab also is coming. Then CAR T cell. So it is a new era in cancer immunotherapy, but still a long, long way to go as far as the non-small cell lung cancer is concerned. So the key takeaway is the management landscape is fast changing in non-small cell lung cancer. The newer therapies, they have a huge potential to improve survival, especially when detected in early stages. The OS has improved across various subtypes with molecular alteration. The ease of oral pills over infusions in case of targeted drug is an added advantage, and pulmonologists will definitely play a huge role in early diagnosis. Hence, it is crucial to involve them in non-small cell lung cancer tumor boards. With this, I would like to end the talk. If there are any questions, we can just answer or we can just discuss. Thank you. Thank you for the patient listening.
Thank you, Dr. Praveen. So that was a wonderful overview of lung cancer. So what is your take on neoadjuvant immunotherapy?
So I think it has already shown promising results as far as if we go ahead with the checkmate 816 trial where Nivo has been used for 2 to 3 cycles, and it has improved the PCR rates from 4% when only chemotherapy was used in historical arm. And if we look at the checkmate 816, it was 25% or 24%, I think. So that was a huge amount of improvement. But we still do not know whether this improvement in PCR will translate into overall survival advantage. Is that it doesn't lead to improvement in the operability of the tumor. So the tumor, it has to be labeled as operable or inoperable at the onset only. So you cannot make a tumor inoperable to operable. So usually that is not the intent. The intent is that those tumors which are operable upfront, so then you are giving immunotherapy just to achieve PCR and to better align the outcome of these patients and to improve the outcome of these patients.
So means to say that stage 3A only. Up to
Yes,
stage
yes.
3A only.
So those patients who are not candidate for surgery, so they should not be given immunotherapy because see whatever we are comparing with is the traditional results which we have with the CRT, with the availability of durvalumab data, Pacific data. So almost 42% of these patients, 43%, so who are otherwise also a poor subgroup. So they are alive at 4 years. So which is a huge improvement. So and if you see the checkmate 816 also, so that outcome data is almost similar to the Pacific data. So I think it is carefully selected patient. If you have a stage 3A patient or probably a stage 2B patient or 2A patient where you are going ahead with a surgical method. So there, uh, if the patient is willing for neoadjuvant immunotherapy, because there is a concern regarding the early progressors also. So those patients who progresses early on with the immunotherapy based regime, so there you are basically delaying the curative treatment for them, and they might not become a candidate for curative intent treatment. And the rationale which was given in these trials, so they were that those are probably the poor patients who should otherwise also not selected for the curative intent treatment. So uh, this is a gray zone that if a patient progresses on neoadjuvant therapy, so that is something which we do not know how to deal with. So, but otherwise, NACT, it is a very good strategy in those patients who have a stage 3A disease, node positive disease, that means N1 nodal positivity. So there it is a very good strategy to go ahead with 2 cycles of Nivo and chemo. you go ahead with the surgery. If PCR is achieved, we still do not have answer whether to go ahead with the nivolumab as a maintenance strategy or not. So, but if you do not achieve PCR, so then definitely you should go ahead with the nivo maintenance also, maybe for a year.
Thank you, Dr. Praveen. Good evening, Dr. Bhushan. Dr. Bhushan is our next speaker. He is from RDCI-RC Rohini, and he will be speaking on molecular biomarkers testing in lung cancer. Dr. Bhushan. Dr. Bhushan, can you listen? Can you hear? Hello, good evening, Dr. Bhushan.
The sir is coming in 1 minute, sir.
Okay.
Sir is stuck in some emergency. He is not able to join, sir.
So then we can close the session.
Yes, sir.
Okay, thank you so much for joining. Good night.
Okay, sir. Thank you. Good night, sir.